Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Hi, everyone. Welcome to Interdisciplinary Case Miles. We are so excited you're joining us today. And I'm Kate, and here are my co-hosts, Sarah and Kelsey. Hi, everybody.
Hello.
We are actually just going to jump into this case today. We are going to talk about a 60-year-old male who has knee OA. So he has pain in the front and inside of the knee with running and walking and basically anytime he's moving, squats, those types of things. The imaging says that he has OA. He's got a little bit of knee varus, which means that it's bowing out. His knee is bowing out a little bit. He's got a little bit less hip extension that I would personally like. And he's got some difficulty going up and down stairs, but he really wants to keep running. And one of the things he has in terms of a question is, what do I do at this point? Can I run? Can't I run? What do I do with this pain? How do I proceed from here? So I'd like Sarah to start with this. And Sarah, this would be a patient walking into your clinic first.
Yeah, so first thing I would do for these folks is take a look at their x-rays, and I think goals are really important. So those are the first couple things I would do. So where are we in terms of osteoarthritis? And then what do you want to be doing? And also, how long has it been since you've been doing what you want to do? So sometimes I see folks, and they haven't run for 2 years and they want to get back to it. And others that are like, I'm just now starting to kind of realize that I'm having trouble keeping up with my normal schedule. And we have a lot of conversations here. So, doing an exam and seeing how significant their symptoms are, what their range of motion looks like. Are they really impaired? Or does their exam still look pretty good? They just have symptoms when they run or soreness afterwards. And so, talking to them about activity modification. So I typically give them the 0 to 10 scale is not the perfect thing in the world, but it's one of the things that we use, one of the tools. So 0 being no pain, 10 is like, take me to the ER, can't breathe, it's so painful. So, if a 3 out of 10 is before we get to the point that we're changing our gait, it's not keeping our attention all the time, I'm not super sore afterwards, and I'm not really feeling like my pain is spiking. Those would all be reasons I say it's okay to continue doing the activity that you want to do, but we just want to monitor it. Now, I always have the conversation with arthritis that oftentimes people don't feel the pain during the workout. It's afterwards, and they'll run through all kinds of stuff and just pay for it the next day. And the reality is what we actually want to monitor is how they feel the next day. So one of the more important reasons to make sure that any kind of activity progression is super slow to give your body a chance to tell you what's going on the next day. In terms of what we do if we're getting to that point that we're getting over that 3 out of 10. So number one, physical therapy. So my friend here, Kate, I would send you these folks to really work on how can we optimize mechanics. Look at that whole kinetic chain. Of course, if they have any reduced range of motion, look at how we can potentially restore that, making sure the quads and the glutes and the core to simplify things, making sure all those things are turning on when they need to be to stabilize that knee as much as possible. I always have folks stand on one leg when they're in the office with me, and that oftentimes gives me a lot of information, even without a single leg squat. Can they stand on one leg and be balanced, or are they losing their balance through their foot, through their hip, through their knee? Do they have this huge body sway? And, 60, have they had anything else going on? Have they had any heart problems? Anything else that can lead to dizziness? Because any of that instability is going to put increased microforces through those joints. And then talking about, well, what can we do if their pain is high and the therapy potentially is not cutting it? Or they're like, there's no way I could do therapy right now because it hurts so bad. So, we have some of the classic things like steroid, which we talk about. There's a place and time for that. Not my favorite option, but if they're really excruciating, having trouble just getting around, it can be a good way to really get pain levels down and kind of normalize things and get them moving through the physical therapy. I really like hyaluronic acid, or also called viscosupplementation or gel injections. It's not a mechanical gel. I think about it more like an oil change is how I explain explain it. So we're giving back some healthier fluid that's soothing to the joint, doesn't come with a lot of risks and side effects. Steroid ultimately over a lifetime can affect the eyes and the bones and the skin and blood pressure and cardiovascular system. A one-off, not so worried about, but if they're getting cumulative doses. And the Visco really doesn't have all those effects. And so it's a healthy thing to use, potentially can be used as maintenance. And then things like regenerative medicine techniques. So I myself do platelet rich plasma. There are also folks out there doing bone marrow aspirate concentrate, or also using adipose cells. So there's a lot of different ways that we can essentially stimulate an inflammatory process, a healthy inflammatory process inside that knee joint to help stimulate some healing to happen. I always tell folks, the place the literature currently is that we are the goal is pain control. If we lay down some healthy tissue, wonderful, but I'm not going to guarantee that we're going to make you a healthy new joint, right? So it's really just trying to regulate that inflammatory cycle that's gotten out of control with osteoarthritis. And there's a delay in terms of the pain relief with the regenerative medicine technique. So we're looking like 6 weeks or so to really start seeing benefits. And so having this whole conversation in context, then of course, insurance and what's covered when. So those are my biggest conversations I have with these folks. We also have some other techniques like genicular radiofrequency ablation, which I don't usually suggest for our runners. Essentially, that's where we're burning the nerves around the joint to reduce the sensation, but we also know that it can affect your proprioception and balance. And so in folks who are doing high impact sports, not my favorite option. And usually that's more of when we're getting to the point that we're thinking about a knee replacement soon. And then we've got replacement options. So we were chatting about this earlier, that we've got partial replacements and total replacements. And there could be a different reason to go through with either of those. But oftentimes at that point, we're having the conversation about how active do you want to continue to be at the point that we do the replacement. But I think two of the biggest things that I would say that would tell me whether or not this person should be running and or we should be considering a replacement: range of motion of that knee. And then, what are their mechanics? So are we able to normalize their gait to something that's reasonable, or are we putting them at high risk for having other injuries? Is their back screaming every time they run? So a lot that goes into this. I'm going to stop there because I could just keep on talking. But that's kind of where I would start in terms of like the actual medical treatments of the arthritis for the knee.
Thanks, Sarah. So for me, I actually see quite a few of these, or I have in the past seen quite a few of these, both people that didn't want replacement, and so they were doing everything they could, so going down that regenerative medicine path, and then people that have gotten to the point where they've tried all of those things and they haven't been able to, they've gone for a little while, but now they need something else, which is a replacement. So in terms of PT, when I first get someone in the office, I have to figure out where they are on that timeline and if they've seen anybody else prior to seeing me. And some of the things that I'm going to look at are same, like look at their balance, look at their proprioception. I want to look at their mechanics, running and walking and squatting. I want to look at their range of motion for the ankle and for the knee, as well as the hip and the back and all the way up, because we're thinking about how load transfers from the foot all the way up and how that's going to look and feel and which part of the joint is going to be getting more load. So I'm going to look at all of those things. The other thing I'm really going to think about is, if their goal is to continue to run, how can I help them run for as long as they possibly want? And one of the ways is training modification. And so I might do gait retraining, so change how they're running so that they are maybe running at a higher cadence. Or I might change their shoes, because some shoes, if it's that medial compartment of the knee, I may want to put them in a little bit more supination, something like that. So I might change their shoes based on where they're having pain and what they look like. I also am going to look at the mobility, like I said, and make sure they have enough mobility so they're not putting too much stress on that knee. And then, of course, the strength around the knee. What can I do to support it? I'm always going to look at the strength component. What does the calf muscle look like? What is the hamstring? What is the quadricep? And of course, I always look at pelvis and core and everything up above as well, but those are the big things. In terms of gait, I'm going to look at their arm swing as well, because I want to know, are they over rotating and putting more strain on their knee than they need to? So those are kind of the biggest things that I'm going to look at. But then one thing that we were talking about previously that I do want to mention is I have seen plenty of people who get to the point where their pain is too much and they really need to do something, and then they decide to have a knee replacement. When you get to that point, you have to often, or in the past, you really had to make the decision, okay, am I going to stop running completely? And What I've seen is that people have done really well with partial knee replacements, and they've been able to continue to run with a partial knee replacement. Now, you really need to talk to the surgeon and talk about the hardware and what the what they think is they should be doing, your patient should be doing with that replacement. But partial knee replacements, I've seen a lot of really good results, and people continue to run. And those same patients haven't been back to me. Maybe it hasn't been long enough. I don't know. They haven't been back to me with a full knee replacement at this point. And they don't always work for everybody. It really depends on what's happening in the knee itself. In terms of full knee replacements, at this point, the suggestion has been don't run once you have a knee replacement. And again, that is something you have to talk to your doctor about and have a full conversation. Of course, there are going to be people that do that anyway. I have seen both spectrums where people continue to run on a knee replacement and they feel fine. But again, I don't know if it's been long enough where they've had to have a revision, or people who have stopped running completely and gone to cross training. So these are all just conversations that we're having. And that activity modification is a huge piece of what we do as PTs in addition to, strength and mobility. What about you, Kels?
Yeah, I was going to ask Sara too, when you see these people present in clinic and you get x-rays from them, do you know, just by looking at x-ray, if, okay, this person's definitely like the regenerative pieces might not be successful and they're going to need a replacement? Or is there kind of this, okay, this is what's happening based on x-ray, we can try it? Yeah, I'm just curious, because if I was in these patients' shoes, I'd want so much confidence if I needed a replacement.
Yeah, so some research behind this and somewhat anecdotal, but basically, if I think a patient has their majority of their pain is bone pain, I don't really expect injections to help, and that includes regenerative techniques. There are some folks out there who are doing things like intraosseous type injections. I don't do those, not so familiar with them, but ultimately, if we put it into the joint, what I'm anticipating it helping with is the soft tissue pain. So anything that's going to come in direct contact with, and the synovium, the sky. So if I'm worried more about edema behind that injury, so the bone that hurts behind the cartilage injury, then I'm worried that it's not going to be as helpful. So a lot of this conversation comes around insurance coverage, right? So regenerative medicine techniques are generally not covered. There's a couple that are, a couple of insurance companies that will cover for knee osteoarthritis, where we have the most of our research. But ultimately, the conversation is, well, let's try the things that are covered first, and then we might potentially try this. There's some folks who come and say, I want to, take the insurance piece out of it and just tell me what you think. And ultimately, I think the PRP, the idea is that some of our more recent literature suggests we can slow down the progression of arthritis with it. And I say suggest because we can't say that for sure at this point, but we can essentially make a healthier joint from it. So we're really looking at the mild to moderate category. So that's before you start getting narrowing of your joint space and you're really just looking at irritation of the soft tissues. With that being said, I've had some folks who had ACL reconstructions and have severe, post-traumatic arthritis, and they've gotten some time out of PRP. So, I tell people, I just don't want to take your money and, have false expectations, but I'm willing to try it. I don't think there's a lot of harm as long as they don't have other contraindications to having platelet-rich plasma. So that's usually the conversation I have with folks. Now, shockwave therapy is also a great thing. So if I think they have bone pain, shockwave therapy is a great thing to actually address the bony lesions and help with that type of pain. There's also more recently low-dose radiation treatments. We are personally not doing them, but I've heard great success stories from that as well. So that's something that's kind of up and coming too.
Oh, interesting. One of the things I like that you said earlier, sorry, Kelsey, is that when people have these regenerative medicine injections, there is a time lag. I thought that was important to point out because I don't know that everybody tells the patient that, and they expect that it'll be better immediately, but it is around that 6-week mark that we really see the difference. And so during that time, they can have an injection like PRP. And then in PT, if you have a PRP injection, getting blood flow restriction training and working on mobility and strength, and that time actually makes a huge difference. So pairing that PRP with blood flow restriction can be really, really beneficial.
And I also find too, if people are having bone pain related to osteoarthritis, if we actually do the modification, so modifying activity, we can turn things around completely and have a new person.
Yeah.
As I imagine, Kate, like taking a period of rest. Like I have someone who's on her feet 8 hours a day at her job, and I'm like, is there any way we can like just rest from that and let things calm down first? And so, really thinking about that, like taking a period of low impact training and seeing where your pain goes. I think there's so much value in kind of reassessing from that as well.
I think that's the art of it, is changing around the program again for the individual and saying like, okay, if you love running this much, why don't we modify that running? But then also maybe take one of those running days and make them a cross training day, or take it and use a body weight support system to offload it. But yeah, I think those training modifications are huge in terms of longevity of runners, and also just for that mental component of running.
And we don't have time for this today, but we definitely need to talk about biomechanical changes in masters athletes, because I think that's a
Yeah.
huge component of this too, is how
Oh my
can
God.
we, yeah.
Yes. And even like step length and all of that. Oh yeah, let's do that. Okay, Kelsey, it's your turn.
Amazing. So I wanted both of you to talk so I could understand a little bit more about OA. But yeah, I think I want to attack it from like an inflammation standpoint, and then like more of, nutrition to support healing standpoint. So with the inflammation part, at first I would kind of like to do similar to what Sara mentioned, with making sure that there wasn't any metabolic disease processes like, labs and lipid panels, and then anything with blood sugar regulation issues, because that's going to affect blood flow too. And so, yeah, if there's any nutrition therapy pieces with, so say, lipid panels or blood sugar management, I would address those areas in a master's athlete. And then also, there's several classes of foods that are anti-inflammatory. Just like regenerative medicine, anti-inflammatory nutrition is going to take time. We know that omega-3s are anti-inflammatory. We know that collagen is actually anti-inflammatory. We know a lot of things are anti-inflammatory, but the need for the consistency around it, like certain enzymes and herbs and spices, and a class of food called flavonoids that are like our teas, berries, dark chocolate, those kinds of things are anti-inflammatory. So there's plenty of avenues we can go down, but making sure that the individual is consistent with that protocol is really, really huge. Also, in masters athletes, we know that thirst receptors are diminished. So they might not be getting cues about when they're thirsty, when we need to change their hydration status. So a lot of times I go over a hydration schedule, because staying hydrated is so critical for supporting the lymphatic system. And then next, the piece of just my normal, healing process of, is this individual retired and now they don't have a formal lunch break? Seeing what their patterns are around their eating. Are they eating consistently throughout the day? Is where they're at in life causing them to not eat as frequently, or not have full sit down meals like we do when, we're working 40 hours a week and we're really excited for our lunch break. So I would say that those are kind of the pieces. I could dive into each of those, but the big things I would want to accomplish with this patient.
See, and that's exactly why you should see a sports dietitian, because those are really great things to add to this, and a really great way to support our athletes. Thanks, Kelsey. I'm going to wrap this one up. I think that we covered a lot. And of course, we really can cover a little bit more on OA when we do the hip OA case. But let's kind of circle back and just give your one thing that you would like in terms of a takeaway from this. And Sara, why don't you start?
Yeah, so I think really meeting the athlete where they are, as we say repeatedly. And so figuring out, what their knee pain is like. Are they actually dysfunctional through the joint itself? Are they just doing too much? Is the biomechanics the issue? Are they going through menopause? Where do we need to kind of start attacking things? And then managing their pain, I think, is huge as well. Because if folks have pain, even if they feel like, oh, I can just muster through it, it's not bothering me, it's still going to affect their mechanics. So making sure that we're treating their pain as well.
Yeah, and I think that mine will be training modification. So modifying their training according to what their body can do, and then making sure that every time they come back and see me, they're not starting at the same point. Because if they're starting at the same point, that means we're not really accomplishing anything in moving them forward. Although I will also mention that some athletes, that's what they want, because it's allowing them to continue running. So in some cases, I will just see them until they're ready to accept that maybe they need something else, some other intervention. What about you, Kelsey?
Yeah, one of our avid listeners said that he's surprised how many times in our podcasts that I can make a nutrition component to a case. And I think that my take home will be that nutrition is always playing the role, whether it maybe helped play into how we got injured or is a piece of the recovery. Nutrition is 100% of the time part of the equation to get back to the training that you want to, or what's realistic.
Awesome. Well, thank you both. And for everybody out there, again, thank you for listening. Please follow us, rate us. We definitely want to hear how we're doing. And if you like this podcast, please pass it along. That's what we're doing. Grassroots, pass this podcast along so that other people can hear it. Coaches, athletes, other healthcare providers. And then, yeah, that's it. So thank you so much for supporting us, and we will talk soon. Bye.